Stay tuned as the doctors look into retinal issues on call. Funding for on-call television is provided in part by
Amerra is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support on-call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Amerra, the Brookings Health System, and Fishback Financial Corporation. The retina is a thin lining at the back of the eye. It is light-sensitive nerve tissue that controls how images are viewed. An estimated 15 million Americans have age-related macular degeneration, but unfortunately, most won't know they have it until they begin to suffer vision loss. We look at this and other retinal issues when the doctors are on call tonight.
Look all around, there's nothing but blue skies.
Hello and welcome to On Call Television. The retina is a thin lining at the back of the eye. It's a light-sensitive nerve tissue that controls how sharply we see. Retinal diseases like macular degeneration, detached retina, or diabetic retinopathy can lead to blurry vision, impairing your ability to do simple household tasks, drive, or even see the faces of your loved ones. I used to call it the film of the camera, but the cameras don't have film anymore. But it's that nerve that receives the light. Tonight we have two very special friends to help answer the questions you may have about retinal diseases. Let's meet our guests. Dr. Eric Thomas, a board-certified ophthalmologist with Ophthalmology Limited in Sioux Falls, South Dakota, is also a retinal specialist. Eric, tell us a little bit about, you did training first in ophthalmology and then you did a rotating internship first?
Basically, after finishing medical school, I did a year of internal medicine, followed by 3 years of ophthalmology, and then after that, did another 2 years of training in vitreoretinal surgery.
And where did you do those training?
I did my internal medicine year and my ophthalmology at the University of Columbia in Missouri, and then my vitreoretinal fellowship was out in Lexington, Kentucky.
And you're originally from?
Aberdeen, South Dakota, originally.
So you came home.
I did.
Yeah. And Ryan, tell us about yourself. This is Ryan Geraets, also a board-certified ophthalmologist who works in the same office and also a retinal specialist.
Sure.
Where did you train?
Down at the University of South Dakota for medical school, and then Texas A&M University for ophthalmology residency, and the University of Michigan for fellowship training. Again, 1, 3, and 2 more years after that.
2 more years after that. So, and then you finish, you practice a year or two, and then you retire. I mean,
Wrapping it up soon.
Yeah, it's a never-ending process. Yeah.
It is. They say we're practicing medicine. It has to do with the years of practice, and you move on, I guess. So let's talk about retinal diseases, because you two both specialize in retinal disease, and I would say that you have to realize that we're going to talk about retinal diseases, but we can talk about anything. These are eye doctors. So if you have an eye question, we'll take those as well. Do you know someone who has a retinal disease? Have you experienced how scary or frustrating it is to have limited vision, or to have learned that your eyesight is deteriorating? Any questions you have about retinal diseases are important, so don't hesitate to ask. On Call is your show, and it's better when you participate. You may call 1-888-376-6225 or submit your questions and comments to oncalltelevision.com and click on the email a question button. So let's talk about the anatomy of the eye. Sure. We've got visuals, and we've got a eyeball, a real eyeball. Is this real eyeball?
Enlarged.
Tell us, let's take it apart and tell us a little bit about it. Go.
So if we take a look at the eye kind of front to back, this is a cross-section of the eye. The cornea is the clear front lining at the surface of the eye. That's the first surface the light hits as it enters the eye. That's responsible for most of the focusing power that the eye has. The colored part of the eye is the iris, and immediately behind the iris is the natural lens. Then there's a large kind of, what shows up as an empty space on most models or diagrams is actually full of thick fluid called vitreous.
Now let me ask you this.
Sure.
So the pupil, this black dot in everybody's eye, is just a hole.
It's just an empty space.
An empty space. Nothing's there.
That's right.
Correct.
That's
Okay,
right.
go on.
In the back of the eye, lining the inside of the back of the eye, is the retina, and that's again using the film in the camera analogy is a frequent one that we'll use in the office, and that actually senses the light. The structures in the front of the eye serve to focus the light, and the retina, lining the inside of the back of the eye, serves to sense the light and help generate that image.
All right, and so that image occurs and the nerves receive it. Eric, take us back to the brain.
Further back. And basically that's what the retina is. It's a direct extension of the brain. Once that image is projected onto the retina, that's transmitted via the optic nerve up to the brain, and then that's where it assembles the data basically that gives you the image that you're seeing.
Right, I remember in embryology, the brain is developing and then a pooch, outpooching comes out, and here you've got these two cups that are the back of the eye. I mean, the receiving part of the eye, which is part of the brain, really. It's
Correct.
an extension of the brain.
Absolutely.
So it's marvelous. Well, then it splits into two parts, and one goes to the left and one goes to the right, and then it ends up in the back of the brain, upside down, right?
Correct. Yeah, the images you see are kind of upside down and backwards, and your brain is talented enough to flip that around for you. So,
So because of this, I suppose there's a number of diseases. What are the major diseases that occur on the retina?
The most common disease that we take care of in the clinic on a daily basis is age-related macular degeneration, followed closely by diabetic retinopathy, blockages within the blood vessels within the back of the eye, retinal vein occlusions, retinal arterial occlusions, and also retinal detachment are probably the most common things that we'll see on a daily basis in the clinic.
Retinal detachment. And they're doing a fair amount of research on these things right now, I suppose. But right now, your basic bread and butter is seeing people looking at the back of their eye, taking pictures of it, and determining what's going on.
correct. That's right. Yeah, the majority of it's done with clinical examination, but with some of the imaging modalities that we have now, you can get a lot of information from those as well.
So we're looking at, and I'm looking through a black dot spot here, and I'm thinking there is a lens, and then there's this hole, and then there's this receiver, and it's sending a message out to you people out there who we're asking to make your phone calls now at 1-888-376-6225, because that's what makes this show. And my first question would be, the most common thing that you run into is macular degeneration. People mostly come to you because they're referred from a primary care doctor or an ophthalmologist. How does that go?
Yeah, typically people will come to a primary care office, whether it's their regular medical doctor, another ophthalmologist, or an optometrist with issues with their vision. And generally they'll work initially with glasses, trying to figure out, is there a way where this patient could end up seeing better just with glasses alone? And if that's unable to be achieved, that's where patients would end up coming to see us if they suspected that there could be some issue with the back of the eye, with the retina, that's causing this limitation to their vision.
Now, when I was younger, I had blurry vision, got glasses, and suddenly I could see. But people who have retinal diseases, as good as those glasses are, you can't make that focus, can you?
That's
Correct. Yeah, especially in something like macular degeneration, where that central vision area is just starting to break down and degenerate, just like the name says. You know, no matter what you're doing out here with the glasses, it's going to hit a limit at some point where you just can't overcome what's going on inside the eye.
So why is it happening? I mean, I know that smoking is probably your biggest risk factor.
That's the biggest risk factor is probably age, actually, even ahead of smoking. But when people hit about the age of 70, about a third of people are already showing signs of macular degeneration. But as far as the degeneration itself, as we start to see that, there's a lot of research going into the various areas of why that's actually happening. We know there's genetic components to it, there's inflammatory components to it, there's aging components. So there's a lot of different branches of research looking at all these various areas.
So, it's interesting that as a person ages, some say that our vascular system gets old, our bones get old, our skin gets old, and it gradually changes into scar tissue. And that's just what happens to us until we get so much scar tissue we don't have enough to make the body work. I mean, that's what aging does. But some people don't get that so fast.
Mm-hmm. That's correct.
But would you say that's a fair thing to say, that the back of the eye is just kind of losing its function and getting scarred down?
In disease states, yes. But even if you look at the kind of the epidemiology of macular degeneration, most people do not develop macular degeneration. It is increasingly common with increasing age, but in the absence of macular degeneration, patients should, or other problems, say cataract or a scar on the cornea or some other reason, patients are still generally able to maintain a very high quality of vision, even 20/20 vision into their 80s, 90s, and beyond, in the absence of other disease states like macular degeneration or the like. So,
now, I've read that the same things that cause hardening of the arteries, atherosclerosis, early heart attack, stroke, all those vascular things are the same things that cause macular degeneration. Is that right?
There's a lot of research into that. They're looking at a lot of reasons for blood flow, both retinal vessels and the choroidal blood flow they talk about too. And that's
choroidal, what's that?
That's a big web of blood vessels basically that lives underneath the retina. And that's where you start talking about the different types of macular degeneration, the wet and the dry type.
Yeah.
When you start talking about the wet type, you get abnormal blood vessels that'll grow from the choroid, which lives kind of underneath the retina, and it'll kind of break through into the retina, and then these blood vessels will leak fluid and bleed abnormally underneath the retina.
That's wet macular degeneration.
Correct,
right?
yes. And they think that there's a lot of pathogenesis in that area that leads to the degenerative process too.
Pathogenesis meaning causing disease.
Correct.
Or disease causing.
Right.
But that's the same thing with diabetic retinopathy, isn't it? The same thing, the choroidal vessels break through and then there's all these fine blood vessels?
Actually, no. The retina has two sources of circulation. The retina itself has the choroidal blood vessels that are between the retina and the white of the eye. And then on the inner surface the retinal.
Start again, because
You bet.
I lost track here.
Sure.
Say it again.
The retina has two sources of blood flow.
Okay.
You have the choroid beneath it.
Behind the retina.
Behind the retina,
Right.
that's right.
Correct.
And then the retinal blood vessels, which are the little red streaks that you'll see if you look at a picture of the back of the eye. Those
Right.
are on the inner surface of the retina.
Okay, so we've got a picture up so you can see blood vessels on the back of the eye. And so there's blood flow that is actually in front of the retina.
That's correct.
Correct.
That's correct.
And that's a second blood flow supply. Is
That's
that
right.
how important is that?
Very,
Yeah.
very. Without either of those sources of blood flow, the eye will not be able to see properly. Age-related macular degeneration affects primarily the choroidal blood vessels beneath the retina. Diabetic eye disease affects the retinal arterial circulation on the inner surface of the retina. So you can have vision loss from loss of blood flow or blood flow derangements on the inner surface of the retina or the outer surface of the retina.
Okay.
So,
We've got questions. We should probably dive into this. Oldham, South Dakota. I love Oldham. I knew people from Oldham, but the name is so great. One of the classic South Dakota tiny towns, you know. 81-year-old, vitrectomy 6 to 7 years ago now. Eyes don't focus the same when tired. Double vision. What will help?
Well, it kind of depends on why they had the vitrectomy, but what a vitrectomy is, first of all, is that's a surgery that we perform to actually remove that vitreous gel out of the inside of the eye. And there's a lot of different reasons that you can have that done. We do that a lot to repair retinal detachments. We also do that a lot in people that have diabetes, where they'll get hemorrhages into the vitreous. So we have to go in there and remove that hemorrhage in there. A lot of times what we'll see after vitrectomy surgery is you'll see a worsening of the cataract. And basically that's the lens inside your eye will begin to get more cloudy, because once you remove the vitreous from the eye, the lens is actually able to get more oxygen, which actually hastens cataract formation. Right. So a lot of people, they'll talk about this post-vitrectomy cataract forming, and basically that's a cataract that forms due to the vitrectomy surgery slowly over time. So it's possible that patient, if they still have their regular lens in their eye, could be having a worsening cataract that could be dealt with cataract surgery.
And before one quick question with a quick answer, okay? I've seen people who go, well, I need to have my cataract But I've heard that when Sally had her cataract removed, then everything got worse. And they were saying that she had macular degeneration all along. So explain that. Is that because the cataract was acting like a pinhole camera and now there's wider view and it's misfocusing, or what?
In terms of issues with cataract surgery and macular degeneration, there have been a number of large studies saying, does cataract surgery cause acceleration of macular degeneration? And I usually counsel patients that it does not. There are a few studies that have implied a very weak link between conversion of dry macular degeneration to wet, but the vast majority have said minimal additional risk.
But when you have a cataract surgery, it never makes it worse?
You have macular degeneration, which will continue to progress over time, and whether cataract surgery is done or not done, that macular degeneration tends to worsen.
So it wasn't the answer, is the real
yeah.
The problem was macular degeneration.
The problem was macular. And we'll often run into folks who are, there's a surprise with poor vision after cataract surgery, and just like it's difficult for them to look out through the cataract, oftentimes it's difficult for the ophthalmologist to look in through the cataract and make that diagnosis beforehand.
Gotcha. Good. Well, as we age, our macula is prone to degeneration, causing blurring and skewed vision. Age-related macular degeneration is common in the U.S., but there are treatments that can be effective if they are started early enough.
Macular degeneration causes changes in central vision. Images which were once clear may appear blurred. Later, dark spots may appear and enlarge. Straight lines may become distorted or curved. Colors may appear less vivid or darker. The eyes work together. When one eye loses vision, it may not be noticed because the other eye is still able to see. Each eye must be tested on its own to identify changes in vision. The symptoms of macular degeneration may be found in other eye conditions. It is very important for an ophthalmologist to perform an examination to ensure that no other conditions are present. Dry macular degeneration affects the health of the retina. The retina is the lining of the eye which responds to light. Here, a cross-section of the retina can be seen. In the dry form of macular degeneration, metabolic end products collect underneath the retina. These deposits are called drusen. Over time, dry macular degeneration can lead to scarring or thinning of the retina above. Dry macular degeneration may cause gradual central vision loss over time. Every patient has a different course, and some patients preserve vision for a very long time. Your ophthalmologist will monitor your eyes. Ask about how stopping smoking or vitamin formulations can help to slow the progression of dry macular degeneration. Wet macular degeneration may develop in patients with the dry form of macular degeneration. In the wet form, blood vessels that are leaky and abnormal begin to grow into the retina. Unlike normal blood vessels in the rest of the body, those seen in wet macular degeneration cause swelling or bleeding into the retina. Wet macular degeneration may cause either sudden or gradual loss of vision as these vessels leak fluid or bleed. If untreated, vision loss can progress. A molecule known as a vascular endothelial growth factor, or VEGF, is released in wet macular degeneration. VEGF binds to its receptors much like a key entering a lock. VEGF is a signal which causes leaky blood vessels to form underneath the retina. As these abnormal blood vessels leak and bleed, the retina becomes swollen and vision may decline. The main treatment for wet macular degeneration is an injection of medication into the eye. This medication is delivered close to the retina after freezing and cleaning the eye, and most patients experience only minimal discomfort.
We'd like to thank Amerra Medical for that illustrative video on macular degeneration. Join our conversation. Call in your questions or comments about tonight's topic. Call 1-888-376-6225. So This was talking about treatment of macular degeneration. I mean, there's this needle going into the eye. That always gives a person a little bit of a squeamy feeling.
Yeah, it sounds a little bit worse than it is. You know, that's the mainstay of treatment now for wet macular degeneration is utilizing medications that we inject into the eye. And that, although it looks awful, you know, we obviously anesthetize the eye before we do anything. And if you talk to people that have had it done, for the most part, they say it's pretty tolerable. So,
yeah, talk to me. I've had it done.
yeah.
Didn't know. You covered that bit.
Yeah.
So the injection, what are you injecting and why does it work? Explain that a little bit.
Sure. There are 3 different medications that we commonly use. And what the medication does is it takes away the signal for the growth of the blood vessels underneath the retina. And by stopping that process, you can usually try to halt the disease where it's at. You've got about a 30 to 40% chance of improving the eyesight. The big deal is stability, though.
So, but why would it suppress the push to develop blood vessels? I mean, how does it trick the eye to do that?
Yeah, there's a signal called VEGF that was discussed in the video, and that VEGF molecule promotes blood vessel growth, it promotes blood vessel leakage, and by taking away that signal, you turn off the blood vessel growth process and you can try to stabilize things.
So it isn't a biologic though, or is it a biologic?
It is an antibody or an antibody fragment that takes away that signal and binds that signal.
It's just wow. And so, I mean, I've just spoken to a number of patients who have gone, oh my goodness, it made a huge difference. But then there are those who said, I can't.
Obviously, the sooner you can catch it, the better.
And what is your take on that? Do you think 50% really good response, 50, 25%?
I'd say if we catch it earlier, it's probably even more than that. I mean, it's kind of, I've explained it to some patients, it's almost like kind of spraying Roundup on a weed. You know, you have these abnormal blood vessels growing there and this medicine gets in there, it can just make them shrink and regress down. And if you can catch it when it's pretty early, you can get those vessels to go away and prevent all that scarring and fibrosis from happening. Whereas if you just let that fluid continue to leak and bleed over time, it just forms a central scar, basically.
And it has nothing to do with the blood vessels anymore. It's all
the fibrotic tissue that's formed. Yeah.
And that fibrotic tissue came from the blood vessel growth, and you cannot recover vision from a flat scar.
So how do you know when's the time? You can tell when it's bleeding.
Bleeding, fluid leakage, fluid beneath the retina, swelling within the retina.
You can see it on your pictures.
On clinical examination combined with the types of scans that we use of the retina, we're very, very accurate in terms of picking up a change into wet macular degeneration. And the sooner you catch it, the better chance you have at stabilizing.
And so how do you catch it? What is the clue that the normal person would say, okay, I need to get that injection?
Yeah.
Well, the main thing is going to be just their knowledge of whether or not they have macular degeneration in the first place. And one of the things that we use as a screening tool is what they call an Amsler grid. And basically it's just on a sheet of paper, it's this little grid with several lines, and we'll have people cover one eye and look at this grid. And normally, you can see that the lines are straight and where they're supposed to be. But if you suddenly have a sudden onset where now you have an area where you have a lot of distortion in those lines, that can be a signal that something's going on. So we tell our patients when they notice that to make sure they call their eye care provider to get in and get evaluated to make sure they don't have something like that going on.
It's essentially graph paper. I have some patients that use Venetian blinds, they use the tile on their floor.
Anything with straight lines.
It doesn't matter as long as the eyes are being watched.
Telephone poles are not straight anymore.
Oh, I hear that one a lot. Yeah.
I hear that one a lot. I saw that.
Yeah.
Wessington Springs, is there a certain age at which you're safe from developing macular degeneration?
The short answer is no, really. I mean, we typically see it in older patients, but I have patients in their 40s that have macular degeneration.
Wow, and is there a clue? I mean, is it because they're smokers or is it because they've had...
It certainly puts them at higher risk, but there's a lot of research going on into genetic factors too, and there's certain genetic factors they can test for now that let us know that you're at high risk for developing advanced macular degeneration at an earlier age.
Okay.
And someday you'll come in with your DNA on a card probably, and they'll swipe it, and
they'll
they'll say, okay, you're at risk for this, and this. And
currently, the recommendations on genetics testing for age-related macular degeneration are recommendations against it because we don't know how to handle that information. So.
Right. Sioux Falls, what is latest therapy for diabetic retinopathy?
Go ahead.
Sure. There are really the same types of treatments that we use for age-related macular degeneration often apply to diabetics. The injections of these same types of medications will stop the leakage of fluid and swelling in the retina. That's the #1 cause of vision loss from diabetes. Still, laser is the mainstay of our treatments for
So let's talk about laser. It's kind of spot welding, right?
Yeah, in a
Kind of,
simple
but
way to
it's-
think about it is like a spot welder. I often will use soldering a leaky pipe for patients who have diabetes. You can cauterize some of the weak portions of these blood vessels and reduce the risk of leakage, reduce the risk of vision loss in the future. Again, somewhat like macular degeneration, you're after stability. Recovery of vision is not terribly common with a lot of these diseases, like diabetes.
Anything to add, Eric?
No, that's pretty much it.
That's it. You cauter those leaky pipes.
Well, there's other lasers we do also in people that have the proliferative kind of diabetic retinopathy.
Proliferative meaning growing, rapid growth.
Correct.
Yeah.
Basically, the eye isn't getting good blood flow, and what happens is abnormal blood vessels start to grow inside the eye, and those blood vessels get very fragile, and they can break and bleed, and that's how you can get those hemorrhages that we talked about. And they can also lead to a very bad kind of glaucoma. And if you leave all this untreated, you can end up losing vision or even losing the eye. And we do a different kind of laser for that, where we use laser to treat the peripheral retina to stimulate these blood vessels to regress and go away, where you're not actually lasering the blood vessels themselves.
We're going to have a case in a bit about a woman who had diabetic retinopathy, leaky blood vessels, caused glaucoma, uncontrolled, lost her eye. Just
We see that more than we would like to.
recently, a friend was diagnosed with glaucoma, lives in an area with without much health care. What can she expect her friend to experience? So, I mean, you've got to monitor glaucoma is the deal, isn't it? I mean, there's a lot of treatments.
Yeah. The good thing about glaucoma, depending if there's different types of glaucoma, the most common one that they're probably referring to is what they call open angle glaucoma. And that's where you can get damage in the optic nerve, usually associated with high eye pressure. A lot of times, well, the majority of the time, if you can catch that early, like a lot of these things, that can be treated topically with eye drops. So they just need to make sure that they're getting in and seeing an eye care provider, getting started on medication if they need it, and then you have to have close monitoring to make sure that that pressure is staying under control, because some people, even with the eye pressure low, they can continue to have progression of vision loss if it's not monitored closely.
But that can be monitored by a nurse practitioner or PA in a rural community, right? I mean, at least, with the oversight of the ophthalmologist.
Honestly, generally, optometrists would be able to continue to check pressure, monitor for visual field changes and things like that.
Yeah,
from
but I
glaucoma.
think a nurse practitioner might have a more difficult time with that just because they're not used to ordering visual fields and interpreting those kind of tests with it. But a local optometrist would certainly be able to handle that. So.
Well, certainly your eyesight is worth making a few mild travels and get
if
to
you have
the eye
glaucoma,
doctor.
absolutely.
Absolutely.
That needs to be carefully monitored.
Yeah, that's right.
Mobridge, one, at the age of 45, oh, here's one, I didn't get to it. Are macular degeneration and deafness related? Isn't that an interesting question?
When we typically hear the words macular degeneration, we assume age-related macular degeneration. There are lots of other forms of macular degeneration where the central part of the retina will degenerate and lose vision over time. There are forms of retinitis pigmentosa, which is a genetic condition where the peripheral part of the retina will tend to become more and more damaged. The patients will lose peripheral vision, lose night vision.
Peripheral vision is
off to the side.
The side stuff.
Correct.
The center is and night vision is this peripheral stuff, right? That's where all the rods are instead of the cones are in the middle.
That's exactly right. And there are forms of retinitis pigmentosa that are very closely associated with deafness. There's a condition called Usher syndrome. There are a couple of different types of Usher syndrome that carry an association with deafness and retinitis pigmentosa.
It has nothing to do with passing the plate and walking them to the different places in church, right?
No, nothing like that.
Okay, and then from Mobridge, at 45, had cataract surgery and retina was burned. Can this be repaired? Retina was burned with cataract surgery. That's kind of, that's one question. And has heard there is something new for macular degeneration. What is it, and when is it available? So first, cataract surgery with retina was burned.
What they're probably referring to there is if you have prolonged light exposure to the retina for a period of time, that can actually cause damage to the retina. And in people that have cataract surgery, if it's a very difficult case where they're having to operate for a prolonged period of time, you have to be really careful about that because prolonged exposure to the operative lights can actually result in some damage to the retina, and they call that a phototoxicity type of injury. Unfortunately with that, there's not a lot you can do to improve that. That's kind of damage that's done at that point. You can't really recover that.
Okay. And then, is there something new that's not available but right on the horizon with macular degeneration?
Quite a few things.
Yeah.
In terms of quite a few things that are new. In terms of your horizon, that's debatable in terms of what's new and what's a little more far off in the future. Lots of different things looking at dry macular degeneration for prevention of pigment loss, other forms of medication to inject into the eye for wet macular degeneration, even other things like artificial retinal technologies, things like that that are even further down the pike. But
So
constant innovation. So.
My dad had a detached retina, and so apparently it was pulling away, it warbled, and at the time, before they had the ability to solder the retina back to the back of the eye, he had to have open surgery at the University of Minnesota, and then he laid there for 2 weeks in the hospital with a bag over his head.
You sandbag your head to keep it immobile, yeah.
Yeah, he said the only thing that kept him not going crazy was the radio.
Yep.
Any comments?
We don't do that anymore.
But what a huge improvement. I mean, you think
yeah.
about the changes, I mean, that we've been able to do. I mean,
Oh, it's pretty amazing. I mean, some of the instruments that we use for surgery to repair retinal detachments are the size of a 25 gauge needle. So if I wish we had one I could show you. It's very small, but it's so tiny. Usually when you pull them out of the eye, the wound is so small they just self-seal.
There's no bleeding, there's no nothing. We're running out of time. We need to go fast because we've got all these questions. Mobridge, aid for cataract surgery, left retina. That one is done. Just diagnosed with Fuchs dystrophy. What does this mean, and what should she expect?
Sure. Fuchs dystrophy is actually a problem on the cornea. There's an inside lining of the cornea that helps keep the cornea thin and clear. Fuchs dystrophy is an age-related condition where that inside lining doesn't pump the fluid out. The cornea can end up swelling, causing some blurriness, halos around objects and lights, things like that. It generally moves very slow, and it's the #1 cause of corneal transplantation. But there are a lot of new techniques with corneal transplantation that are way better.
Squeezing implant in the back of the cornea.
Yeah, actually they transplant only the inner lining of the cornea rather than the full thickness of the
You're able
cornea.
to peel that off and put a new one on,
You
basically.
got to have good tools to do that.
Yeah.
Yes.
Not all retinal issues happen slowly over time. Over 10 years ago, diabetic patient Elaine Hedburg lost the sight in her right eye after sudden eye pain one afternoon. These days, she still performs her daily routine, but with one extra task.
I was trying to do some wallpapering, and it just came on very sudden. I called the eye doctor, and when he looked at it, he said, "This is serious, we need to do some laser." However, it was too late. My body had already made extra vessels somehow and pumped the moisture into the eye, so the lasers didn't help. I have no vision on this side. I didn't have, at the time that I lost the vision, they told me it's a chance I would lose that eye, but it wouldn't be for a long time. And I'm sure it was like 10 or 11 years before it just got so painful that I would catch myself holding my eye shut because just the air was painful on it. So it was removed, and then I have my prosthetic eye. When they removed the eye, they put an acrylic ball in there, and then the scar on the front of the eye is what this one kind of, there's a little dent there where it just fits on. But by the time when they removed the acrylic part, or the eye, and put the acrylic ball in there, then all the muscles in my eye stayed the same, and so that's why my eye moves. First of all, you have this little suction cup that you take your eye in and out with, and well, I'll go ahead and show you that first. And so then you wash it with baby shampoo in warm water and dry it with a soft cloth and put it back, and so then it's nothing to really be afraid of, and there's absolutely no pain whatsoever with it. You just don't go without doing it because you think it's going to be a miserable situation, because it's wonderful compared to the pain that I had before.
Call in some questions for at 1-888-376-6225. Thank you for your questions, and you can email them as well. Sioux City, Iowa, the bottom eyelid is pulling away, causing dryness. What can be done to help? People have these eyelid droopy things that let your eye get dry.
Yeah, they can. The one they're talking about there is what we call an ectropion, where the musculature in the lid just weakens over time and it can kind of fall away from the eye. You can also have a condition where the lid rolls in, called an entropion, and that's where the lashes will rub on the surface of the eye. It can be irritating. They can usually fix that, though, with a minor lid procedure.
Right,
Actually, so.
quick little
Kind of
tuck
in-office deal.
sort of a deal. Harrisburg, South Dakota, macular degeneration, can it be prevented? Is lutein helpful? Is there a genetic connection?
Well, yeah, we talked a little bit about the genetic connections earlier, but as far as prevention, we don't really have a way to prevent macular degeneration from happening, but if you've already been diagnosed with macular degeneration, you can decrease your risk of developing the more advanced form or the wet kind of macular degeneration by using the eye vitamin supplements. The most recent study on that is called the AREDS 2 study. That was performed and finished up over this past summer. It's been going on over years, and they finally got that data done this summer and released the new formulation for that. So anybody looking at the eye vitamins, the most up-to-date formula with that's going to be what they call the AREDS 2 formula, and that'll be right on the bottle that you can get over the counter. So.
And I don't mean to counter your promotion, but I mean, I was looking at the studies, and of course it didn't make a lot of difference for preventing it when it's mild or early, right? You got to be pretty late.
That's right, yeah.
And it made a little bit of difference. So I mean, I think we have gone crazy on the eye vitamin stuff, and the real truth is you need a balanced diet, you need to exercise right, and you don't need to smoke.
Those are all things that actually that AREDS 2 study also said those exact things that you just said.
All right.
The smoking is fourfold increase in your risk. I mean, so when we have patients who are smokers and we're talking about vitamin use, which reduces your risk by 25%, I mean, we're ignoring the elephant in the room. If you quit smoking, you get a 400% decrease as opposed to 25%.
Right.
Yeah.
Sioux Falls, floaters. What about floaters? What are they, and how do you fix them? Floaters and that vitreous thing. Let's hear about that.
Yeah, they're very common. They're benign. You can have
benign meaning they're no big deal.
They don't hurt anything, right? Basically, little clumps that form in the gel in your eye. You can get floaters that are more severe that are associated with other conditions, but if we're just talking about kind of regular floaters, basically, we don't typically do anything about that. We usually watch that. They can be a nuisance for people, and typically people do okay with it. Your eye tends to kind of get used to those over time, and you can ignore them. But in some people, they can be severe enough where we do need to talk about surgery, that vitrectomy surgery that we talked about.
Because it has to do with the vitreous,
correct,
doesn't it?
Yes.
And the vitreous has got some junk inside.
Yeah.
Now, does everybody's vitreous separate like mine did at a certain age of their...
Yeah.
It increases over time. Generally, it's about 10% per decade. So 50% of 50-year-olds, 60 or 60-year-olds, and so on and so forth. So if you live long enough, chances are the gel will eventually degenerate to a degree where it will peel away from the retina, and you'll have some new floaters swirling around in the eye.
And no big deal. Most of the time, you've said leave them unless they're pulling at perfect spots in your eye that you're losing vision because.
And occasionally, if the floaters are severe, they can obscure your central vision, and they don't really move. They can kind of lock into place sometimes. Don't see that a lot, but in people like that where you're very dependent, I've had to do surgery on a pilot before. I had a person in training that was a sniper in the military that they couldn't, look through their scope. So there's certain scenarios where you would recommend surgery for that kind of thing.
Right. Had cataract surgery and a week later had a torn retina. Is this common?
Not common, but it has happened on occasion. I mean, one thing with cataract surgery and retinal tears or detachment is that any surgical procedure to the eye will tend to cause that vitreous to liquefy at a faster rate. And if that liquefies and peels away, that can create a break or tear in the retina. So loose association, slight increased risk over time. So.
Okay. Is there such a thing as an eye transplant? Not yet.
Unfortunately, no. The only thing we can
Yeah.
transplant is that cornea that Dr. Geraets was talking about earlier.
Yeah.
So.
Or
Or the lens, or
the
your
lens.
natural lens.
True,
That's right.
yeah.
Yeah, I remember when people would come in with these massive pop bottle glasses.
The cataract
That's right.
glasses, yeah.
Yeah.
And then when they developed the lens implant, it was one of
yeah,
these
great.
huge marvels.
Yeah.
Eye transplant, we asked that. How about third nerve palsy, double vision? Please discuss. What's that? Third nerve palsy. The third nerve is one of the cranial nerves,
That's right.
and there are 12 of them. And the loss of the third nerve can occur from what, and then what's the result?
Sure. There are 3 nerves that run the eye. The third nerve runs the bulk of the muscles that kind of direct the eye. The most common causes of third nerve palsies are blood vessel diseases, high blood pressure, diabetes. Occasionally you can have tumors in the brain that can push on the nerve and create a third nerve palsy, or aneurysms that can push on the nerve and create a third nerve palsy. Unfortunately, because of the number of muscles that are involved with the third nerve, it's the most difficult palsy to treat in terms of management of double vision. Generally, the goal is to realign the eye after you've given it plenty of opportunity to see if it's going to improve on its own, as it occasionally can. The goal is to try to have single vision with both eyes open, looking straight ahead and in a reading position, and that's about the best you can do, unfortunately.
So people who get chickenpox have a nerve that's involved, the shingles.
Sure.
The people who have mononeuritis multiplex, in other words, one nerve is involved, or you get a cranial nerve on the face, and people who have Bell's palsy, and it goes away and then it comes back. Is that sort of what that might be, the same type of thing? There could be a virus that swells a nerve and then it depletes it for a while. Is that how that?
Generally, we would think of it as a blood flow issue rather than an infectious process.
Okay.
So usually lack of blood flow from diabetes, high blood pressure, and all your other coronary artery disease risk factors, just like for macular degeneration.
Yeah. And the person with third nerve palsy, their eye is just going to be in the middle and won't be able to move like the other ones.
It actually it drifts down and out, and oftentimes there's a little bit of a droop to the lid as well.
So the story gets even worse, doesn't it?
Yeah, it's a difficult problem.
Do you treat with steroids or?
Generally.
For that?
Yeah.
Generally not.
Typically, no.
That's not much to do. We have from Mobridge callers, constant tears spilling over. What causes this, and is there anything to do to help?
There can be a lot of different, that's a condition that's called epiphora, and that's where you have excess tears that spill over the lids, can even be running down the cheeks sometimes. A lot of times you can just get that, believe it or not, from dry eye, because when your eyes make 2 kinds of tears. There's one tear that kind of lubricates the eye to keep it stable, and then there's another tear that comes out when the eye is irritated, like if you get an eyelash or something in your eye to help wash it out. And what happens is when the tear that lubricates the eye is diminished, the eye gets irritated. So you start to make these reflex tears that come out, and they're really good at washing stuff out of your eye, but they're horrible for lubricating your eye. So one thing you can do to address that issue is just to use artificial tears, believe it or not. Put more tears in your eye to try to lubricate it better. And as the eye becomes better lubricated, those reflex
irritated.
tears will abate on their own. Now, if you have a blockage issue where the eyelids can't drain the tears out, that's something you sometimes have to get probed, or sometimes they have to do surgeries to kind of open that up better.
So that's it. There's a place in the inside of the ear along the nose that takes the tears and drains it, and sometimes that gets plugged, and you can go in there and push the tube down there and probe it out.
Sometimes the eyelid can even become lax, and the tear drain, instead of sitting up against the eye, will kind of pooch out, and it just won't collect them. And they'll
like that
trickle down.
ectropion that we talked about before, you can have that sometimes.
So just like everything else in medicine, it's not a simple little.
Definitely
It's
not.
not a
no.
simple answer.
Yeah.
I mean, it's a complicated story.
Yeah.
I love what you said about 2 kinds of tears. I mean, I did a research thing. I don't know if my essay when you were here last was on tears, but I wrote about the fact that it is a lubricant, it's a protein, it feeds, it does all these wonderful things. It's got a little oil, so it's, the central part of the tear is different than the outer part of the tear. I mean, it's just an amazing story. Who designed this? Gee. Here is, I had a hole in the retina which was plugged. Now he has poor eyesight. Any idea how this can be fixed? Hole in a retina which was plugged. Now there's this issue about retinal holes and so on and so forth. Explain what that is.
Sure. You can have holes in the retina in all sorts of different places. There are 2 types that we would think of. One is a macular hole that affects the very center part of the eyesight.
Right.
And that's where a patient would actually have symptoms very similar to macular degeneration, where the central vision would become distorted and there'd be a large blank area in the middle of the eyesight. And, you know, as recently as 20 years ago, this was thought to be untreatable. Nowadays, we have a very high success rate with hole closure with surgery. We would remove that vitreous gel, peel off a membrane on the inner surface of the retina and close the hole. That generally improves the vision, but it's not as good as it was before the hole would develop.
Wow.
Peripheral retinal holes can lead to things like tears and detachment of the retina.
Right. The holes, why did the holes occur?
Abnormalities in how that vitreous gel separates from the retina.
Yeah, there we go. A caller had a cyst on her eye, eventually it went away. What could have caused the cyst? And I'm thinking the cyst is on the retina? On her eye. I bet you it could be a meibomian cyst or whatever.
It could be on the conjunctiva, the thin skin over the white part of the eye, although she could be talking about the eyelid as well. Those are very common to get what they call a chalazion,
Yeah.
where you can get little oil glands and other types of glands that live in the lid get blocked up. A lot of times those do get better on their own if you just give them time. You don't want to try to pop those and get rid of them. A lot of times just using a warm compress and keeping it warm so the body can kind of break that down and get rid of it on its own. So.
Okay, I take medicine Plaquenil, and I'm told to have fields tested every year. Is that really needed? This is from, it doesn't say where it's from.
And the answer to that is absolutely. Plaquenil is an rheumatoid arthritis drug, so it suppresses the immune system to help with the arthritis. It can accumulate in the layer of pigment right underneath the retina and create damage to those cells and cause vision loss. Now, it's uncommon with Plaquenil, but the longer the patient takes it, patients who are very small, who have a very low ideal body weight, are more likely to have issues with Plaquenil accumulation and toxicity.
Higher dose.
Higher and dose related as well.
And they lose visual fields.
Actually, central vision. Central
Oh, wow.
vision, and unfortunately, it's irreversible if it happens. So we want to catch it early.
Okay. Retinal tears are repaired by laser and freezing. What determines which procedure would be employed, and what about freezing? We talked about retinal lasers. What about freezing?
The freezing is called cryotherapy, and that's actually been around longer than the laser has. Everybody's a little bit different. Typically, I'd say myself, anyway, I typically treat retinal tears mostly with laser, but sometimes you can have patients where it can be difficult for them to position their eye, or the tear itself may be in a difficult location to reach with laser, and in those scenarios we would use the cryotherapy instead.
And that's you put your hand, you have the stick and it's frozen.
Well, you anesthetize the eye, and then you have a probe. Basically, it kind of looks like a little stick, and then you have a little pedal that you push, and that causes it to freeze. You can actually see a little snowball form on the tip of the stick, and you put that against the eye, and the freezing will go through the wall of the eye all the way to the retina, and that forms a little scar, basically, that'll form between the retina and the wall of the eye.
There's no difference in success rate between the two techniques.
All right.
Right.
So.
Okay. Can anything be done about thinning of the retina because of nearsightedness at 74?
Unfortunately, no. No.
So it thins and you just lose vision.
Yeah, the more nearsighted you are, the longer the eye is, so that retina is stretched out and thinner. And that's actually, you can get a condition that they call myopic degeneration, which that same kind of degenerative process happens just due to the thinning of the retina over time. We don't have a way to reverse
And we
that,
can't fix it, we can't prevent it.
Not yet. Not at this point.
I have watery left eye for 24 hours. It comes in waves about 5 to 10 minutes, makes my eye want to close. It makes my left nostril run. What does this sound allergy or cold? They just got a puppy 5 days ago and hoping they're not allergic to the puppy.
If this just
Sounds
started
puppy to
5
me.
days ago, you might have bad news.
It sounds allergic to me, doesn't it? And,
Yeah,
and of course,
if they didn't have this before and now they have it, I'd be leaning heavily towards the allergic.
and the drainage tube is not plugged because the person's
that's
got a
right.
stuffy nose.
Yeah,
They can feel.
the runny nose is from
Runny
a
nose.
tear.
Yeah, it's the tear running in the back.
Yeah.
And no comment, you agree? Allergy,
Yeah,
work.
most likely.
Go to an
Most
allergist.
likely.
See if you can check out that dog. Following an eye procedure, clot debris increased the amount of floaters in the field. Following an eye procedure, can a patient expect those floaters to be absorbed by the body over time?
Generally, yes. Unfortunately, time can mean different things. It could be many, many months if there's a fair amount of blood before things washed out. If there's enough blood and debris in there that is not washing out, sometimes we'll end up doing that vitrectomy procedure to try to clear the media. So.
Is there a medicine that will dissolve coagulated blood or vitreal fluid in the eye?
That will dissolve the fluid in the eye?
Yeah, is there a medicine that will dissolve coagulated vitreal fluid in the eye?
Well, there's a medication that's relatively new called Geraets, which you can inject into the eye to try to get the vitreous to separate from the retina, which I think that might be what they're talking about. Success rate's pretty low on that. It's only about 40%. We don't use it a lot. In some people, that vitreous, as it's pulling on the retina, that can cause some problems that we talked about. Usually surgery fixes that, but in some patients, maybe if they're too ill to have surgery or something like that, that's a medication we would try. So.
Right, I read about that in anticipation of my own problem, and I said, no way.
I've actually had fair luck. And as long as it's being advertised as about a 50-50 deal, the advantage is that sometimes you can avoid the vitrectomy surgery if you end up using the Geraets and it works. But I think patients need to understand right away that there's a very real chance we could do this injection and we're still going to the operating room.
Okay, we're running out of time. Ocular migraine, quick answer?
Don't have to worry about it typically. Resolves on its own.
Wondering about secondhand smoke with macular degeneration?
Less a risk than being a smoker yourself, but
still
still a
It's
risk.
still there.
Yeah.
Are there physicians in Sioux Falls that do treatment for wet macular degeneration right in
here.
this
You're
room?
looking
They're in Brookings right now. So.
Yeah, that's right.
They're up in
Currently in
Brookings.
Sioux Falls, no, but there's 2 in Brookings.
Yeah, anything new on retinitis pigmentosum, and we've got just 30 seconds.
Yeah, artificial retina.
Yeah.
Is the
10
next
seconds.
thing. Yeah.
There's what?
Our artificial retinal technologies, very early, but very promising.
All right. We'll be back right after this.
With 2013 behind us, our thoughts turn to romance. That's right. We're entering a time of year symbolized by none other than the flu bug. Did you know flu season usually doesn't peak until February, sometimes even later? Why take chances? It's not too late to get vaccinated, because stopping the flu starts with you.
If you had to lose one of your senses, which would be the most devastating? Imagine losing vision and how bad it would be to no longer see the beauty of a sunset over the prairie or the kind twinkle in grandmother's eyes. Play out losing hearing and no longer being able to listen to Beethoven's Fifth Symphony or the babbling of a mountain brook. Consider these or losing the senses of touch, smell, or taste, and it helps one appreciate the 5 senses and empathize for those without. One day at work about 5 years ago, I noted my right eye was blurry at the center of vision. It struck me at the end of the day that I was losing some center vision in my right eye, and after a few days it seemed to be getting worse. In short order, I was at the eye doctor and learned the problem was related to the bag or sac of vitreous gel which fills the center of the eye. This bag of fluid was apparently separating from my retina, pulling and distorting vision. Well, my ophthalmologist sent me to the retinal specialist. After taking pictures of the retina and following up over several months, he finally advised surgery. This involved removing the vitreous sac, called a vitrectomy, followed by peeling off of the inflammatory membrane that had formed over the light receptor retina in the back of the eye. Since then, my vision has stabilized with some loss of fine vision, but enough remains to make me really appreciate what I have with my left eye. I've had many patients with vision loss, including one who lost an eye from a bottle rocket, and several farmers who had similar traumatic loss of one eye. I know of glaucoma patients diagnosed late with vision loss and of diabetics with progressive overgrowth of leaking blood vessels and significant blindness that followed. However, in my practice, most vision loss occurs in elderly patients with macular degeneration due to unknown causes, although sometimes it's related to smoking. I've always sensed the sadness and loss these people experience as their vision goes away, but never so much as when I started to lose mine. Well, this brings us to the end of our show this evening. I surely, truly thank our studio guests, our good friends, Dr. Thomas and Dr. Geraets for helping answer all the questions about retinal issues from our audience tonight. Wonderful questions. Thank you all for those phone calls. Helen Keller, for whom blindness was one of several obstacles in her life, put sight in this perspective. It is a terrible thing to see and to have no vision. Thank you again, both of you, for being part of this. And until next time, stay healthy out there, people.
Funding for On-Call Television is provided in part by
Amerra is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubak with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On-Call is provided by the generous support of Amerra, the Brookings Health System, and Fishback Financial Corporation.
It'll be a stream.
Oh, I got you.
So later, if they hear the questions that didn't get answered,